From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today, we're going to discuss a new insight into the shortage of primary care clinicians in the U.S. It's not just that there are fewer primary care physicians per person, but there are other variables in play that affect how easy it is to find a primary care clinician when you need one. And we know that it's not so easy. In fact, the share of American adults who do not have a usual source of primary care has grown by over 20% over the past decade. To help us understand this crucial but complicated issue, I'm joined today by Dr. Kate Majzoub Morgan, who did a study that helps us understand the actual availability of primary care in the U.S. She is a primary care physician at Brigham and Women's Hospital and a research fellow in medicine at Harvard Medical School. Welcome, Dr. Morgan.
Thank you. Happy to be here.
And we are also joined by Dr. Ishani Ganguli. She, too, is a primary care physician at the Brigham and an associate professor of medicine at Harvard Medical School, as well as an associate editor at JAMA Internal Medicine. Welcome, Dr. Ganguli.
It's great to be here. Thank you, Eve.
So we're a trio of Brigham PCPs here, and so I'm hoping that over the next few minutes we can celebrate some potential solutions to the challenges in primary care. And so, Kate, maybe you could set the scene for us and help us understand why it's important to look at more than just the number of PCPs per person. And I'll note that in this podcast, we'll be using the abbreviation APP for Advanced Practice Providers, including physician assistants and nurse practitioners.
Thank you. Yes, my colleagues and I first started thinking about this question in the context of seeing more and more people in our community coming to us saying that they could not find a primary care physician, despite a very high number of physicians in our area. I had noticed similar things in a more rural area, which was flagged as a primary care shortage area. But in Boston, Massachusetts, it seemed very surprising that it was so hard to find a PCP. We also knew that although the declining number of practicing primary care physicians in the U.S. is well described, there were some other signals that something else might be going on. For example, a study in 2024 showed that primary care physicians had self-reported reducing their panel sizes by 25% in the past decade. We also knew from a study published in JAMA Internal Medicine in 2023 that physicians were cutting back on their work hours over the last decade. And we wondered if perhaps the number of primary care physicians was not the only thing we needed to look at. Maybe we needed to also see what services were primary care physicians providing in the context of this decline in panel sizes and work hours.
That just rings so true as we see sort of all of the factors affecting primary care clinicians and burnout and workload that people are cutting back. In your study, you found a new way to look at this actual availability of primary care. So can you tell us what you did and what you found?
So instead of looking just at the number of practicing primary care clinicians, we decided to look at the services that they were providing, and specifically looking at new patient visits, thinking that in the real world, when somebody needs a primary care physician, that's really what matters, is how many clinicians are accepting new patients. So we used 100% fee-for-service Medicare claims data between 2013 and 2021 to look at how the number of clinicians available to see new patients and the number of new patient visits delivered changed over time. And we also wanted to look at how primary care physicians versus primary care advanced practice providers were contributing to these new visits.
Why sort of look at both primary care physicians and APPs?
We were aware that some of the solutions to the primary care physician shortage really focus on increasing the number of primary care APPs. However, we hadn't seen any rigorous data showing whether this was actually happening in practice.
And so tell us about what you found.
We found that over time, there was a persistent decline in the number of primary care physicians accepting new patients, 23% decrease actually from 2013 to 2021.
That's enormous.
Yeah.
You know what I mean? Like that's like in 10 years, 23% decline. That's a lot.
Yeah. Unfortunately, not so surprising to us, but definitely a lot. Interestingly, we also found that the number of APPs available to provide new visits increased by 105%. So overall, however, there was a 5% decrease in the number of clinicians available for these new visits.
And that's just because there were fewer APPs to start with. So it didn't offset the difference.
Yeah, the increase in APPs didn't offset the decrease in physicians.
So I'm going to now turn to Ishani and just ask you to talk a little bit about why that decrease in primary care availability matters so much.
Yeah, thanks, Eve. And I want to start by saying that I know that I am part of the problem. I'm not taking on new patients in
Yep.
my part-time practice. And I won't speak for the two of you, but it's a real issue. So I would say that Kate's work really highlights that having access to primary care entails so much more than we've been able to glean historically from national data, right? So it's not just about having the right ratio of PCPs in your area, but these PCPs have to be open and able to take on new patients, which Kate and her team's work have really nicely illustrated that challenge. And then even if you have a PCP, you have to have a timely visit, be able to have a timely visit. That PCP has to be able to offer one, and then to be able to offer the host of activities and team members and resources needed to really provide high quality primary care. So there's so many steps along that access timeline. And I have to say, this really hits close to home. So my parents are in traditional Medicare. They moved to a new state in March, that was 9 months ago, and they're still waiting for their new PCP appointment. I did find them somebody who was taking on new patients. They have very limited slots for new Medicare patients or new patients in general, and that appointment keeps getting bumped up. Now it's in January, and they're really struggling. They really want somebody to be that sort of quarterback or whatever analogy you want for their care. And it just reminded me how important this kind of work is and how big the challenge is.
A huge challenge. And I imagine that it's particularly noticeable in Medicare as you think about the aging population and then sort of the needs for medical care there and the sort of increasing complexity over time.
Exactly.
As we think about that, it's just making me wonder if you have thoughts about what some of the reasons might be for this kind of dramatic decline in access over the last decade.
Building on what Kate said, I think the nature of the work has changed and our payment models have not really evolved to meet those needs. And so there's a lot more complexity of medical care that patients need, or even we just understand more about disease states and different types of counseling, and there's more preventive care to offer. And so primary care has gotten a lot more complex. And there's also been a new profession, the hospital medicine, and sort of this divorce, if you will, between hospital medicine and primary care in many settings, such that hospital medicine may seem more appealing to some folks who have done residencies where that is what they are trained to be good at. And so we have seen this trend in which people are going more and more to hospital medicine. So there's a number of different factors. I would say that COVID did not help the situation where it was a really challenging several years where primary care was in many ways at the front lines of the pandemic, but wasn't supported to really do that work. And so what we're seeing is the effects of that. But I do think there's hope, so we can talk about that too.
So give us some hope. So for either of you, what are your thoughts either coming out of what you found in this work or just thinking more broadly about ways to address this shortage? What do you think are some achievable strategies to shift this trend?
Based on our study, it's very clear that APPs have become a core part of the primary care workforce. And the solution is going to depend on how well we can design our systems to make the most of the APP workforce and the physician workforce, and really thinking thoughtfully about what each profession has to bring to primary care. So I'll start with that. But Ishani, what do you think?
Yeah, so I guess I would make three main points. One is I think we need better data, and Kate's paper starts to get at that. We need to understand just at a national level who is doing what work and the extent to which it's full or part-time. We don't have a good sense of that, although Kate shared some data that gets us closer. So doing this at a national level would be really useful. The second is thinking about payment, and so changing payment models such that they better support the full set of activities and team members needed to provide high-quality primary care. And as Kate's paper shows, APPs sort of don't have the capacity to fully address the limitations in primary care workforce right now. And it's important to recognize that APPs are also subject to the same incentives that physicians are, in that, if a specialty practice pays more and has better infrastructure, they will want to work there. And that's completely rational and understandable. And then changing payment again to really be able to support high quality primary care. And the final bucket is thinking about changes to medical education, finding ways in the undergraduate and graduate settings to really expose trainees to the joys of practicing primary care. And there are so many of those. And then also thinking about other targeted strategies like loan repayments that are specific to primary care.
I hear all of those things you're saying. I also want to just highlight when you say showing the trainees the joys of primary care. I think there also has to be changes to the practice of primary care that allow that joy to shine through. We can't model it for our students if we're not feeling it. And so what are the ways to improve team-based care, to take away some of the work that doesn't allow us to do what we do best, which is work with patients in diagnosis, management, counseling to make a difference in people's health and well-being. When you talk about changing the payment model, what do you hope for from that?
Yeah, I think there's two pieces. One is when I talk to residents I work with as a preceptor, for example, it becomes clear that the financial incentives to enter a certain specialty versus another are understandably a big piece of the decision making. And so making primary care payment more on par with other specialties is one piece of it. But I think a more important piece that's really about the patients is ensuring that both the amount and the structure of primary care payment allows you to do the full complement of work that's necessary for high quality primary care, meaning supporting not just physicians and APPs, but other members of the primary care team, like pharmacists who are embedded in clinics, like paying appropriately for medical assistants and nurses and social workers, et cetera, and also paying in a way that's more flexible and holistic, so per member per month payments. There's some new policies coming out or that have come out that do that in Medicare. And that all combined will allow us to experience the joys of medicine, practicing primary care as clinicians that we can then genuinely share with our trainees, not just faking it. So
I deeply appreciate your focus on the economic solutions needed to improve primary care accessibility. At the same time, I also want to acknowledge that it might be important to think about what can be done within the constraints of our existing financial system, including medical education changes, team-based care approaches, reconsidering immigration restrictions on international medical graduates, and especially important, leveraging technologies including telehealth and artificial intelligence to reduce burnout and improve workforce retention and recruitment. Thank you so much, both of you. I've so enjoyed talking to you both about this important work in understanding the primary care shortage in the U.S. I'm Dr. Eve Rittenberg, and I've been speaking with Dr. Kate Majzoub Morgan and Dr. Ishani Ganguli about understanding the primary care workforce shortage. You can find a link to the articles we discussed in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.